Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clipmax. Thank you for joining me in my latest video using the iClearScope endoscope. And that still image you saw at the beginning of the video is of a grade 3 Keratosis obturans removal. And that is a plug of dead skin. And in this particular case, it came away in one large singular piece. Now, you're joining the video about 10 minutes in. I initially used the wax scope, and at the end of the video, you can see the opening 10 minutes of the procedure using the wax scope, but I decided to revert to the iClearScope endoscope just to get the better field of view with a Keratosis obturans, because a Keratosis obturans is a benign accumulation of dead shed skin, and it forms into a plug, almost like an onion, so you have layers upon layers. I always actually refer it to a rubber ball that expands and gets bigger, because when you're removing a Keratosis obturans, it has that sort of texture. It can be really elastic, quite firm, and in this case, it was rock solid. It was almost like stone. When I was making contact with the surface of this, it was almost pinging back. Now, with a Keratosis obturans, it normally forms in the bony part of the ear canal, which is the inner 2/3 of the ear canal. So we call that the osseous portion. And it's basically dead skin that's shed but has failed to migrate. And there's many potential causes for that, which I will discuss a bit later. In terms of how common Keratosis obturans is, I think the statistics suggest about 4 to 5 in 1,000 patients that attend an audiology or ENT clinic. I would suspect that's actually a bit, the prevalence is a lot more than that, but sometimes Keratosis obturans can be just misdiagnosed for an earwax plug. But this is Keratosis obturans. This patient first attended 4 years ago, back in 2020, and when they attended, they explained that they were experiencing severe ear pain. They visited a couple of other companies. They went to A&E, given how bad the pain is, and our local accident emergency department in Leicester, where I'm based, one of the doctors knew or heard of me, so recommended the patient come and see myself. And when I removed the Keratosis obturans last time, 4 years ago, I did advise him to come every year annually. But upon that removal, the patient didn't really exhibit any symptoms until recently. And that's the problem, because it's a benign condition. Patients with a Keratosis obturans are somewhat unaware that it's reaccumulating, and you naturally forget about it. When they attended last week, their main symptoms was a blocked ear. They did experience some pain, but not as much as their original appointment. Now, this patient's only got this Keratosis obturans in their left ear. This is the left ear. So about 50% of cases do originate in one ear only. And one of the potential reasons why patients can get the Keratosis obturans is if they suffer from sinusitis or bronchiectasis. And it's believed that when you have sinusitis or bronchiectasis, it stimulates the sympathetic reflex pathway, which then, as a result, causes a dilation of blood vessels. And when you have a dilation of blood vessels to the ear, that promotes the production of more skin cells, and the more skin cells your ears secrete and produce, the more eventually dead skin that you're going to accumulate in the ear. And Keratosis obturans is actually a condition that's most common in more younger patients. So between the ages of 20 and 40, in fact, the decade in which you're most likely to experience this is between the age of 30 and 40. And that can go back to the theory about blood flow. As we get older, we're going to have reduced blood flow to the ear, and therefore less production of skin, and therefore shedding of dead skin. The statistics suggest that females are more common to experiencing Keratosis obturans. I'm just thinking anecdotally if that's the case for me. Possibly yes, but I do have probably an even split, if truth be told, but I would have to look at that further. But yes, I do have quite a few female patients suffer from keratosis obturans. Now, when a patient presents with keratosis obturans, there's some common clinical symptoms that they present with. The most common, probably the hallmark of keratosis obturans is an acute ear pain. So it's not a dull pain, but it's a really sharp, acute, sudden onset of pain. And there's been cases with patients in the past who have had keratosis obturans, they've had to undergo general anaesthetic given how painful it is. If a patient presents with pain already and you're then attempting to remove that without any anaesthesia, of course it's going to be even more painful for them. They, of course, experience a conductive hearing loss where sound can't travel through the ear canal and vibrate against the eardrum. And in some really severe cases, you're talking about your grade 4s, because there is a grading system, so this is the grade 3. But with a grade 4, some patients can attend with facial palsy, so this can compress and widen the ear canal so much that it can compress against the facial nerve, which runs in the middle ear, but also in the back part of the ear canal. It can also cause a dehiscence of the tegmen tympani. So the tegmen tympani is a thin plate of bone which separates the intercranial compartment and the middle ear. But that, again, it's very rare. It's only grade 4s. But yeah, the most common symptoms are, of course, reduced hearing and ear pain. Now, another hallmark of keratosis obturans, and you've seen it in the still image and you'll see it once I remove this as well, so that the most peripheral layer is kind of like a silvery white matrix. Patients with keratosis obturans can also get a thickening of the eardrum because they have excessive amounts of keratin, and keratin is a protein found in dead skin, and the outermost layer of the eardrum is actually made up of dead skin. Another hallmark with a grade 2 onwards of a keratosis obturans is a global widening of the ear canal. And you'll see it in this patient. They've got quite a significant widening of the bony part of the ear canal, quite medial towards the eardrum. And that's due to a process called bony resorption. So when you have a plug of skin that compresses against the ear canal, it kind of activates specialist bone cells called osteoclasts. And what osteoclasts do, they break down and dissolve bony tissue and minerals, and that bony tissue and minerals is redistributed into the bloodstream to other parts of the body where new bone can be formed. So the specialist bone cells that produce new bones are osteoblasts. So the bone in our bodies, it's always recycling itself. The outer layer is always being broken down and replaced with new bone, and it's just to help keep the integrity of the bone so it's always strong and durable. The differential diagnosis between a keratosis obturans and other conditions that sometimes you can misdiagnose it for, such as a canal cholesteatoma or benign osteonecrosis. So with a canal cholesteatoma, it's a very localized widening erosion, and you typically have an ulceration of the skin, so the skin that lines the ear canal is missing. With a keratosis obturans, the skin is still intact. With a canal cholesteatoma, you typically get some discharge, some kind of pus infection. With a benign osteonecrosis, so this bony decay, again, that's very localized. And sometimes patients can present with a benign osteochondrosis and the ear canal is unoccluded, it's patent. And with a benign osteonecrosis, the erosion is typically on the floor of the ear canal. Another hallmark with keratosis obturans, if you have a grade 3 and above, is, and you can see it here, you have what we call contact bleeding. When we remove the plug of keratin, especially against the canal wall, you disrupt and kind of destroy new blood capillaries that are formed. And that's because with a grade 3 and above, you typically get granulation tissue where the cartilage meets the bone. So that's the outer third of the ear canal. And that's just due to the compression of the plug of dead skin. It's really pushing up against the canal wall, so it's causing trauma. As a result, your body produces inflammatory tissue called granulation tissue, which is effectively connective tissue. And this connective tissue undergoes a process called neovascularization. It forms its own blood capillaries. So when you're removing it, you actually rupture some of these blood capillaries and you get bleeding. So that blood you saw there, it's not anything that we did ourselves. It's just when you elevate and lift the plug of the keratosis obturans off the canal wall, you're also disrupting these blood capillaries. Now, there's four grades of keratosis obturans. Grade 1 is your kind of your least severe, and it's when patients attend typically with mild pain. But when you remove the keratosis obturans, there's no discernible widening expansion of the ear canal. Your grade 2 patients typically attend with moderate to severe pain, and there is a noticeable expansion of the ear canal. It can be mild, but you're able to notice it. Your grade 3, which is what this patient has, is moderate to severe pain, and you get a moderate expansion of the ear canal, which you will see at the end of the procedure. And then you'll get granulation tissue at the osteocartilaginous portion of the ear canal, so the outer third, which again is visible there already. Your grade 4 is your severe pain. You have severe expansion of the ear canal, and sometimes patients can develop an automastoidectomy. So that's when this bone where I'm working on now, it's widened so much that it merges with the mastoid bone, which is the bone at the back of the ear canal. So it resembles a patient with a canal wall down mastoidectomy or a radical mastoidectomy. I've come across one before, and they needed to be seen by ENT. In fact, they had surgery upon visiting ENT. ENT assessed them, and there was no way they were going to remove that without the patient undergoing general anaesthetic. Quite often with a grade 3 keratosis obturans and above, you also get inflammation of the canal lateral to the formation of the keratosis obturans. So sometimes it gives you a pseudo appearance, that inflammation of the osseous portion of the ear canal being wider than it is because the cartilage in front is inflamed. So you've got to be just wary of that. Just going back to some of the other causes of a keratosis obturans, so patients with skin conditions, so eczema, seborrheic dermatitis, or an infection of the hair follicle, furunculosis, or patients who suffer from chronic inflammation of the ear canal. All of this can either produce more dead skin or increased blood flow, which then, as a result, results in increased skin formation. As mentioned previously, the more skin that's formed, eventually the more dead skin that you're going to produce in the ear. So the inflammatory cause is one. So even if you're poking in the ear, you can increase blood flow, and potentially you could then later result into a keratosis obturans. Then you get the silent type, which is just where the skin itself is abnormally shedding and migrating. So typically the skin that lines the ear canal, as it dies and sheds, it migrates sideways from the deepest region of the ear canal, so even off the eardrum towards the entrance. Eventually the skin sheds and it falls out the ear by itself. And also, when the skin is deeper in the ear canal, the individual skin cells are interconnected, but as the skin migrates towards the entrance, once it's shed, the individual skin cells should separate from one another. And but with keratosis obturans, the skin may not migrate laterally from the deepest region to the entrance. Instead, sometimes it can shed almost towards the midline. So it's an abnormal migration. And also, the individual skin cells fail to separate from one another. So you have this interlocking dead skin cells, hence why we call it a bit like an onion. You have a lamellar structure. In terms of treatment, in this case, this patient's got the silent type, so it's a more chronic form. So it's due to this abnormal skin separation and migration. So this patient needs regular or cleaning of the ears. Sometimes patients can be prescribed anti-inflammatory drugs because, as mentioned, increased inflammation, increased blood flow, more skin that's being produced, eventually more dead skin that's going to form, which can then potentially form into a plug. Sometimes patients can undergo surgery, so to reduce the widenings of the ear canal, because once you've got a widening of the ear canal, it's not going to help the migration of skin. You want the ear canal to be a smooth architecture to allow a good migration. If you've got these bumps and divots in the ear canal and trenches, the skin finds it harder to migrate. So ENT can perform split skin grafts to reduce the widenings, or alternatively, instead of reducing the widenings, you can kind of widen the narrow parts of the ear canal. So, as long as you've got what they're trying to achieve is a smooth, consistent diameter of the ear canal from the eardrum to the entrance. So, ENT can perform a canaloplasty to widen the narrow portions of the ear canal to make it more equivalent to the widening that's already occurred. So you're kind of remodeling the ear surgically. Now, this patient, at times when I was trying to remove it, they were experiencing a bit of discomfort. It was such a rock solid piece, and it came out in one go. So what I was trying to do, sorry, I was talking more about the condition and not the procedure. You're trying to separate this plug of skin from the canal walls, but it's attached. You can see all this white peripheral dead skin here. This was also attached to the Keratosis obturans, and I took some of it away when I removed the plug. You're going to see the widening in a moment. They just got a bit of humidity. So this is the widening now. There's another layer forming. There's no ulceration here. This is the next layer of skin that's failed to migrate, and it's occurring in this widening. So I'm trying to peel it away, but this patient kept getting dizzy, experiencing vertigo due to the caloric effect. So we just left that in the end because the patient couldn't tolerate it. Now they also have got quite a deep posterior superior retraction where there's keratin embedded. You can see here, I'm going to remove that. But there's no underlying cholesteatoma. So this region here is the posterior superior quadrant of the eardrum. It's sucked in, it's retracted, so it's formed a pocket, and you can get a formation of skin there. So I managed to remove the bulk of that. I just wanted to make sure there's no underlying cholesteatoma, which there wasn't. There's some skin superiorly. So the whole medial section of the ear canal is widened. There was a bit of skin left in the roof, and I did try and attempt to remove that, but as mentioned, the patient kept getting dizzy, so we just called it a day at that stage. You can see the granulation tissue just bottom right of screen at 4 o'clock. There's a bit more deeper in the ear canal. So yeah, I used the metal instruments to kind of separate it. It wasn't working. I used my Rye instrumentation, and the one that really worked well was the Rye ear pick. In fact, I developed the Rye ear pick specifically for Keratosis obturans because of its low profile. I can glide in between the canal wall and the plug. So the eureka moment in this procedure is when I was able to glide it on the posterior canal wall and push that plug from right to left to the middle, which then allowed me to get a better grip with the forceps. I used the forceps quite a lot in this procedure, and every time I was pulling it away, I could feel it move slightly, but I could feel there's a resistance. So the tail end of that plug was trapped in that widening. So you're trying to remove a plug of rock solid dead skin out of the ear, but the more distal end, so the furthest end, was actually bigger than the front portion of the ear canal. So physically, it was almost impossible to begin with. But once I manipulated the plug and pulled it out of that trench, I was able to get the forceps. But every time I was using the forceps initially, the patient was experiencing a bit of discomfort. So we had to stop. You can see the eardrum's thickened there. There's some keratin there near the umber anteriorly. So I'm just going back here. So when the patient did get dizzy, I did pause. The caloric effect, which can sometimes happen when you're moving a Keratosis obturans or working close to the eardrum, is when the temperature of the ear canal is reduced due to the suctioning in this case. And that inhibits the function of the vestibular organ, the semicircular canal. So this left ear was sending less signals to the brain than the vestibular organ in their right ear. So the brain was getting a mismatch of signals, and it tricked the brain basically into thinking the patient was moving, but they weren't. So they developed vertigo and their eyes were rotating. So after a minute or two, it does increase in severity, the vertigo, and it kind of subsides. So we're having breaks, but I think we had about 3 or 4 breaks because of their vertigo. And this is the last part I was trying to remove, and the patient experienced a bit more vertigo. So we just stopped at this end, at this stage. So it goes without saying, the patient was extremely delighted once we removed this. And in fact, we've starting to do this now. We send or contact the patients ourselves as reminders. Didn't really want to go down that route because it can, when you're a private business, it can come across as almost like you're trying to seek the patient's business by calling them. But some patients have requested that if we can remind them. So we're doing that more now with our complex cases, where we just leave a note in our diary in a year's time, and our clinic manager will contact them. And in this case, this patient really does need, even if they don't have any symptoms, we don't want to go down this route again. So I first started off with the wax scope, and I'm trying to use the right angle instruments. I don't know whether you can tell just by watching it, but it was almost impossible gliding this through and poking it in. It was just too rock solid. And then I'm going to go around the edges. I'm going to use the forceps to correct the ear pick. Again, the ear pick did work quite well. Now, so in total, this procedure is almost 30 minutes. And I think with a grade 2 plus grade 3, that's actually, on average, the amount of time it takes to remove. I've got a playlist on my YouTube channel. Feel free to visit. So if you just search the hair clinic or the wax whisperer, you'll come to my YouTube, if you're not watching on YouTube, that is, YouTube channel. And there's a playlist of Keratosis Obturans, and you'll see that most of the procedures there, they are quite lengthy. It's a very difficult thing to remove. It's something that I've become more and more accustomed of doing, is I do get a lot of referred patients or patients that have gone elsewhere who haven't able to remove it, and the patients then find my YouTube channel, ironically, watching my other procedures. There is a knack to it. There's no shortcuts really. Some of you may think, well, why didn't you just pull it out? Well, if you watch the video, you'll see that I was literally with the forceps pulling, and I don't like using the phrase, but trying to yank this out, but it just wasn't coming away. So this is the back part of the ear canal. This is where the wax scope is quite good with these manual instruments, because you get such high magnification. We can, especially with the ear pick, which has got a pointed end, you can be really precise in where you position it. So I'm just trying to separate this piece of hardened skin keratin, and I'm just leveraging it. And a piece came away here, but that was really insignificant. There's a lot of little fragments, flakes of skin that I removed during the procedure, but the main one was that plug that you saw at the beginning of the video, or the thumbnail if you're watching on YouTube, and I'll have another still image at the end. I'm just going back to the front part of the ear canal, just reducing the brightness slightly because there's a lot of skin. I'm just trying to glide this pick in, but this is the bit that was really rock solid. You can probably see by the consistency, the pick just wasn't going in, but I managed to then glide it in there. I think I'm going to go to the bottom of the ear canal, trying to leverage this up. So I'm gliding underneath. The way I can probably describe myself using the manual instruments is when you've got an old tin or even a new tin of paint, and you're trying to open up the can, and trying to take the lid off, where you get a screwdriver and you're leveraging the screwdriver. So you're trying to get the screwdriver into the part of the lid that's sealed around the can itself, and you then push the screwdriver down to leverage the distal end up to separate the lid. It was exactly that. In fact, ironically, I'm doing a bit of home renovations, and I'm doing a lot of painting, and just the other day, it was after the procedure, I had an old can of paint, and I was trying to open it, and it was really stuck. So I got a big flat screwdriver, and it just cast my mind back to this procedure. I thought that's exactly what I was doing in this patient's ear canal. I was really, you can see there. So imagine that being the flat screwdriver. You're getting in between the lid of the can of paint and the can itself, and then you're maneuvering the screwdriver in the opposite direction, so the distal end moves superiorly. So essentially, the handle of the screwdriver I'm bringing down, which means the tip is going to go up, and that leveraging motion, you're trying to separate it. So I'm also going to use the correct in a moment. But here's the forceps again. So I've got a good grip then. I'm just pulling. It just wasn't budging. In fact, it just teared the end away. So it is a nice piece to grab onto. It's protruding outwards. This is where I felt the endoscope actually, because of the keratosis obturans, it's really compressed against the canal walls. The endoscope's good for that because you get a better visual. But actually using the manual instruments, I found was in some respects easier with the wax scope because, as I said, it's so magnified. You can get a really precise positioning of the instrument. The last thing we want is the tip of the instrument poking against the canal wall and causing pain. So I think in a moment you're going to see the contact bleeding. So the contact bleeding is when, there we are. So we're separating this plug. So we've not made contact with the patient's ear canal at all. But what's happening is the granulation tissue has formed its own blood capillary. So it's undergone a process called neovascularization. So when we're separating this plug from the canal walls, we're rupturing these newly formed blood capillaries in the granulation tissue, and it bleeds. But once we remove that, you'll see there was no bleeding afterwards. So it's not trauma caused by ourselves. And you can begin to see that white silvery matrix. So again, I'm just using the suction. Suction wasn't really that beneficial, truth be told, but it just helped clear up some of that blood. And at that point is when I reverted to the iClearScope endoscope. So that's that still image, and that just came out in one piece. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.